Today's lecture is an introduction to neuroimaging. We'll talk about the theory and mechanisms behind imaging as well as the practice and clinical application. If you remember back at the beginning of the semester, I talked about light and how a lot of things that we discover in this course are by means of light. We talked about microscopy and a lot of discoveries that have been made in neuroscience, even from the very beginning with Ramon y Cajal discovering neurons and Golgi staining neurons and this principle that neurons are the basis of thought, and then progressing through all sorts of 3D imaging and fluorescent labeling and other important scientific experiments that have elucidated the mechanism of cells and neurons and developmental formation. Well, now we're also going to use light, but in a little bit different way. We're still going to use photons, which are the force mediator of the electromagnetic force, and we're going to see how they elucidate neural tissue structures, both with CT scan using X-rays and also with MRI using nuclear magnetic resonance. My goal in all of this is hopefully to help you transition from undergrad to grad school mentality. Undergrad, it's kind of assumed you don't know anything, but you've learned quite a bit actually, and in grad school it's kind of assumed that you either know things already or that you will take the initiative to learn them on your own, even though you might have very little context for what you're learning. And so, especially for those of you who are going off to med school, you'll realize that soon enough that a lot of your own learning depends on your own efforts, whether that's reading textbooks or asking the right questions, searching information, and finding mentors who are willing and able to teach. So there's not really going to be a neuroimaging course per se to prep for your specialty, but obviously you can read a lot of textbooks that are very good and have been written on this subject, and you can try to do rotations with neuroradiologists and obviously pay close attention and practice on your neurology and neurosurgery rotations, and that all that alone will put you light years ahead of other students, which is really good if you go to a program that expects you to manage things on your own and interpret your own scans. Most times that a patient comes through the ER or is admitted to the hospital, we've taken them to the OR and had them in post-op before a radiologist can ever actually look at the scan. So transitioning to this mode where you can actually look at scans and get comfortable is really important. And I hope this lecture sort of bridges that gap and at least gives you a nice introduction to the things that are going on in imaging. So there's a lot we could cover here. Obviously, it can take years and years to get good at neuroimaging. And so I've tried to choose the things that are most interesting and most relevant to both the theory and also to the clinical practice. Obviously, I always try to cover both the theory and mechanisms behind something as well as the clinical application. But I think this lecture in particular is probably one of the most useful parts of the course for you, because you'll see that as you go off into the world and you start families and things happen in life, that eventually you'll find either yourself or your own family members in the hospital. And I think with this introduction, you can at least know what you're looking at and possibly be of some help to yourself and your family in interpreting things that occur quite commonly, and not just come out with a neuroscience degree but have no idea how things are actually visualized in the medical world for neurological diseases. All right, to start off, just for fun, I thought we could start with the most basic of imaging modalities, X-ray. And this kind of shows you the complexity that goes into even just an X-ray. Looking at a chest X-ray might sound like something simple, but it actually is a refined skill that is really important and takes some practice. So just for fun, you can look at these X-rays and try to guess what's going on with them. Usually I like to ask you guys and see if you can figure some of this out, but I'll just kind of go through these for fun. The one at the bottom right is just taken off the internet. It's a psychiatric patient who has swallowed a butter knife. You can probably see the outline of the butter knife clearly in the esophagus there. And that is a suboptimal situation. But the rest of these actually come from my trauma surgery days. So I just thought I would put them up here. The top left one, you can see some clues there. You can see some staples near the armpit, near the patient's left armpit. So as with all medical imaging, typically the patient's left is on your right as you're looking at the screen. There's actually an L there too that indicates the patient's left. So this was a young man who decided it would be funny to put his arm out the window and hit his neighbor's mailbox, and it basically ripped his arm off as he drove by. So that is not a good situation. This has a lot of things going on in this chest X-ray actually, and this is kind of post-op, the first of a couple surgeries. So this involved plastics and ortho and vascular surgery and lots of people. But you can see post-op here, if you look over at his right lung, there's actually something wrong with his lung. You can look around the edge and see that the top edge of the lung is kind of near the sternum. So this is a collapsed lung on the right side. Somehow he had a collapsed lung on the opposite side where his arm was torn off, and that can happen when you tear any sort of tissue in the pleural space, and you can also see a lot of atelectasis in the base of the lung. It's the darker white tissue. This wasn't causing any breathing problems at the time. It wasn't a tension pneumothorax, but it certainly could have become one, so it just involved putting a chest tube in to let the air out. Now, the image at the bottom left is also a trauma situation. There's some clues here of what happened. You can see some dark, round, small beads. Those are actually shotgun pellets. This man was shot in the chest by his wife around Christmas time, and this guy came in, and his wife actually came in the ER as well because she was concerned about him apparently. But you can see here that there's some drains and chest tubes and central line put in. And I'll outline some of these on the next image, but it won't be apparent the first time you look at these, and it really does help to be able to adjust the contrast and be in a dark room and things like that as well. But that was this scenario. The chest X-ray at the top right was a patient who came in with chest pain, and normally that would get worked up as a possible heart attack, a myocardial infarction of some sort. But what frequently gets missed is another thing, which is semi-apparent here. You can see there's a very wide mediastinum, so that white tissue directly above the heart is much wider than it normally should be. And this is an aortic dissection. This is where the intima of the aorta has torn and there's hemorrhaging into the wall of the aorta. And this is also trauma and an emergency and needs immediate attention. I think there was a couple famous people actually who've died of this because it was missed as a heart attack. But anyway, just something else to think about there. So those are just some basic chest X-rays. You can determine a lot just through a simple chest X-ray. Now imagine if we can turn this into a high-resolution 3D image. That would make a powerful tool in medicine for all sorts of things. So I've started off here with some learning objectives. I know you guys like to know how this will be tested and what's on the exam. So this is kind of a summary of what you should know. We're going to talk about the basic differences, including advantages and disadvantages of all these imaging modalities, CT, MRI. We're not going to talk about PET today. Actually, I've cut that out of the lecture just for brevity. And then angiograms as well, including CT angiograms and MRI angiograms, so magnetic resonance angiograms. And I just want you to understand the basic physics of each imaging modality. We're going to go into a bit of detail. Don't panic if it seems overwhelming. You just have to know the basics. And if you pay attention and take notes from this lecture, I think you'll do well on the questions on this section. So don't feel like you need to know the mathematics in detail or anything like that. I'll point out exactly what you need to know. And then I want you to understand the basic clinical use and application of each imaging modality. So we'll talk about that as well. All right, so let's start off with CT scans. So computed tomography. CT uses an X-ray beam which rotates through many angles to assemble a complete 2D image. So has what I would call an XY component, a horizontal and a vertical component, as you can see in the CT scan of the brain at the bottom right. So a CT scan is basically representing the tissue density from an X-ray beam's point of view. So something dense like bone is not going to let a lot of X-rays pass through, and that is going to be underexposed and show up as bright white. Less dense tissues like brain are obviously going to have a lot more X-rays pass through. And in order to get the proper contrast amongst slightly different densities of brain tissue, you have to adjust the windows so that you can look at the low densities of brain tissue. If you try to look at such a low density of brain at the same time as looking at a high density of bone, the brain is essentially going to look washed out, and I'll show you an example of that later. But you can actually distinguish different densities of the brain just from X-rays, including the difference between cortex and white matter and things like that. So a CT scan makes these 2D images, which can then be assembled into 3D images as well and make a reconstruction in 3 dimensions. So this next image shows the basic construction of a CT scanner. You can see that it has a large hole with an X-ray generator on one side and an X-ray detector on the other side. And this whole contraption actually spins around, as you can see in the next video. So when this was developed, this was really brilliant technology, but it's actually become so simple that now it's considered a quite simple technology. You can even go on medical mission trips to Africa and have little transient clinics that have CT scanners. And so CT scanners are really useful because they're basically ubiquitous, they're fast. You can use them for all sorts of just quick general inquiries, especially in trauma. So typically people will be scanned to see if there's any major organ damage, broken bones, things like that, any major hemorrhages. And in comparison to most of medical care, it's relatively inexpensive. But the disadvantages are that it produces a lot of ionizing radiation. X-rays can damage DNA, and that exposure is significant. For one CT scan, it's usually 2 to 20 millisieverts. So just to give you an idea, one chest X-ray, or I should say one chest CT scan, will typically be about 70 chest X-rays. And that one CT scan can increase your cancer risk by about 0.7%. I remember reading this in the Journal of the American Medical Association when I was in med school. I was one of those nerds that actually subscribed and read it. And this came out, and it was pretty surprising how big of increase that is just for one CT scan. And it is dose dependent. So the more CT scans you have, your risk rises significantly, even to the point where it can be in the range of the Hiroshima survivors who had, they studied a large group of them that were exposed to about 50 millisieverts. I think there was like 25,000 people in that group. So if you have a whole body CT scan that's about 20 millisieverts, then you can basically end up with a similar dose of radiation to being in the perimeter of an atomic bomb explosion. But you also have to put it in context of what our average daily exposure is to the ambient environment. And so on average, that's thought to be around 3 millisieverts per year. So in the scheme of things, typically this is said to produce about 1 death that unnecessarily per 2,000 CT scans, or about a 0.2% incidence of cancer. 0.2% of cancers can be explained by exposure to CT scan, and that may be higher now that CT scans are much more common. Some studies have suggested that, but just something to think about. The last disadvantage is just that you only get one type of image contrast. It's just how dense is the tissue to X-rays. There is nothing fancy you can do here, unlike MRI, as we'll see. So let's just start off by jumping into MRI, and I'll show you these examples of different imaging modalities in MRI. So here you can see things called T1, T2, flare, DWI, and ADC. So these are all different imaging modalities. Each one of these is looking at the tissue in a different way. So this isn't just like CT scan where you're just looking at X-ray density. We're looking at different behaviors of the tissue in response to a radio frequency pulse. And I'll explain that more in a minute. But let's just look at some common characteristics of these images. So on a T1 image, you can see that it represents the actual physiologic tissue quite well. The outer cortex looks dark, the gray matter. The inner portion, the white matter, looks white. The cerebral spinal fluid looks dark. And so these things are all characteristic of what you would expect on a nice detailed image of the brain. And you can see here as well, all these images, or at least the top three, are much higher resolution than CT scan. These, if you zoom in on them, are nice and refined. They're not the blotty sort of CT image that you typically get. You can see on the T2 image, everything looks kind of inverted. The cerebral spinal fluid, the water, is white. In fact, I always remember T2. For some reason, this is stuck in my head. 2 is spelled TWO. The water is white. You can remember the W in it. Water is white. That's a fundamental characteristic of T2 images. Also, the cortex is inverted here. The cortex looks white. The white matter looks darker. And you can see that on all of these, the bone doesn't respond very well to MRI. It doesn't give much of a signal. Now, the images at the bottom, the DWI and the ADC, these are quite low resolution, but there's a reason for that. These are representing the ability of water to move through the tissue. They're diffusion-weighted images. So a diffusion-weighted image is showing how well can water move through this tissue. And in an area where there's stroke, where tissue has died, you'll see much greater movement of water. And that's why that white spot appears in the internal capsule on the patient's right in the DWI image. That's showing a small infarct in the tissue. Likewise, the ADC is kind of like an inversion of the DWI image. Not quite, though. I'll explain why later. But the ADC stands for apparent diffusion coefficient. And here, that is showing up as a dark spot on the internal capsule, showing a small stroke. Now, what is the basic premise of MRI? What's the mechanism? It might seem quite confusing at first, so I'm going to explain it in a couple different ways, and hopefully one of those sticks and makes sense to you. But we're going to start really basic. So the most basic way of explaining this is that we're going to put you in a magnetic field, and all your protons are going to align in the direction of the magnetic field. And then we're going to send a radio frequency pulse right into your body, and that, remember, electromagnetics, every photon carries an electromagnetic component, so this is going to have a small magnetic field, and it's going to tilt the angle of that alignment of protons in your body. It's going to tilt it slightly just for a brief moment. And then, after that radio frequency pulse is absorbed, all those protons are going to want to realign with the magnetic field. And as they do so, they're going to give back energy, the same energy that was absorbed. They're going to give it back as another radio frequency signal, but they're going to give it back over time. And that radio frequency signal is then going to be reabsorbed into the coil. It's like an antenna that sits near the body, and it's going to be reabsorbed in a particular way. It's going to be given back from the body and recorded through this through this coil, and we can interpret the signal that goes through that coil in a specific way that lets us actually look inside the body without sending anything but photons through it. So it's a really cool technology that probably didn't make any sense to you, so it helps to look in more detail now. So believe it or not, MR imaging is based on the same principle of nuclear magnetic resonance as the NMR studies that you did in your organic chemistry lab. So there's some important additions, but basically it's the same thing. So we have a proton in the body that has an angular momentum, p, and a magnetic moment, mu, the Greek letter mu. It's like a tiny spinning bar magnet. And you can see at the bottom left there, the proton, it shows its spin, and the magnetic moment can be thought of as the strength or the magnitude of the magnetic dipole generated by the proton. And it is defined by the amount of torque, tau, T, that will be felt by the proton's magnetic moment, mu, in an externally applied magnetic field, which we typically call B. So the formula here is that torque equals mu cross product B. This is not just a simple multiplication problem. I'll show you in a minute. And again, as with most things, it kind of helps to think of this with classical mechanics. Now, we obviously have to make a large caveat here, which is classical mechanics does not apply to quantum theory or quantum mechanics, and so it's not precise nor accurate to talk about it in this way, but it is a good analogy that helps explain things. So if you think of a spinning top, and I made this little video of a nice gyroscope, a gravitational field will cause the spinning top to precess. And so in the same way that torque will equal the radius of the gyroscope cross product with the gravitational field, similarly, the torque represents in a proton is the change in angular momentum that occurs in a magnetic field. And so we can substitute these torque equations to get this really cool equation called the Bloch equation. So the Bloch equation was made by Felix Bloch and Edward Purcell, two famous great physicists, and they ultimately won the Nobel Prize for this work. And they basically showed how the magnetic resonance of a proton can be explained, and it's with this nice differential equation. Remember, we talked about differential equations and how whenever you have the derivative of something, in this case, the magnetic moment mu, the derivative of that in some way equals itself, the result is always going to be an exponential function, e to the power of something. Well, what we're doing here is we can't pick up the signal of each individual little proton, but we can pick up a general signal from all the protons summed together. And so we're going to call that capital M, a bulk magnetization vector. It's basically just the net force if you were to sum up all the directions of all the different directions of the proton orientations. Now, if you remember quantum theory, you'll think back and remember that protons are thought to be made of quarks, 2 up quarks and 1 down quark. And these have partial charges, up quarks a plus 2/3 charge and a down quark minus 1/3. So they still sum to a plus 1 charge in a proton. And interestingly, at least at the moment, it's thought that quarks really only make up 2% of the mass of the nucleus. And it's thought that the rest is actually made by this cloud of gluons that's popping in and out of existence, these sort of quarks and antiquarks, that and the gluons mediating the strong force. So it's this bizarre world that we just can't comprehend from our fundamental classical understanding of mechanics. But we're just going to take it at face value that there's an uneven distribution of charges in the proton, and for whatever reason, that makes the protons line up at an angle to a magnetic field. So typically, the proton will not line up straight with a magnetic field. It'll be about 55 degrees off to the side. Now, it's going to be precessing, just like the gyroscope does. So not only does the proton have a spin, but it has a precession rate, and that precession rate is directly proportional to the strength of the magnetic field. So in the image there, the proton could be angled to the right like it is, or it could be angled to the left if the magnetic field is going straight up and down. So the proton's just going to be precessing around the straight up and down line of the magnetic field. Now, it turns out that you might think that the protons have an equally likely probability of distributing themselves either parallel with the magnetic field or anti-parallel, as it's called, with the magnetic field. But the energy states have a favoring of the protons in the direction of parallel with the magnetic field. It's very slight. It's only about 10,001 protons to every 10,000 protons that are in the anti-parallel direction. And if it were even, if protons perfectly evenly pointed in either direction in a magnetic field, we would not be able to get any MRI signal. So it turns out that this is a fortunate little cool phenomenon, and that one extra proton that is out of 10,000 that's more likely to align in the parallel direction is what really gives us the net signal of the MRI image. So a stronger external magnetic field will make a larger difference in the number of protons that are in the parallel state, and so that's part of why stronger magnets are used for better images. They have a higher signal-to-noise ratio. However, they also have an increased inhomogeneity in the magnetic field, so a little bit of distortion and inaccurate imaging there. So there's a lot of research in that area currently. Most clinical MRI machines have a good signal-to-noise balance at 3 Tesla. So you can see in these images the magnetic moment of the proton precessing around the vertically aligned magnetic field. You can imagine that B naught field, the B with a 0, B naught going straight up and down. Just imagine that is going through the tube of an MRI scanner. And I'll show you the machinery a little bit later, but imagine that straight up and down arrow is the tube that you lay in the MRI machine. Now, the protons are going to precess around that. They stay at a 55-degree angle to that. But like I said, the precession rate will be directly proportional to the strength of the magnetic field. So you can do these really easy calculations where the precession rate, omega, will be given by gamma, this constant gamma, times B naught. The constant gamma is called the Lamour frequency, and this makes a really easy calculation. For example, if I tell you you're in a 3 Tesla magnet, and I want to know how fast is the proton precessing, you would just take the gamma constant, 42.5 megahertz per Tesla, times the magnetic field, 3 Tesla. So that comes out to about 127.5 megahertz, which is right in the FM radio frequency. That's part of why you need to shield these rooms from radio frequencies. The next image is just showing how these protons are randomly aligned without a magnetic field, and then once you introduce a magnetic field, they begin to align either in a parallel or anti-parallel direction. And obviously, the stronger the field, the more in alignment they will be. We have a weak magnetic field in the Earth, which is not significant enough to align these in a meaningful way that we can extract a signal from them. And then this next slide just shows the block equations. This actually popped up on my final exams in biomedical engineering. It said solve the block equations, and this was my approach, and fortunately I remembered how to do it. So just a cool little way there if you're interested in that. Now, after all the protons are aligned in the magnetic field, we've done the first step of MRI, but we haven't actually extracted a signal yet. So we're going to use a short radio frequency pulse that produces a secondary magnetic field, and we're going to call that magnetic field B1. And that's going to be applied perpendicularly, which tilts the magnetization vector away from its normal alignment. So in this image, the direction Z represents the direction of the main magnetic field B naught. And we're going to, when you sum up all the different protons that are aligned at 55 degrees to this, they're all going to cancel out in terms of the XY direction. Some will be off to the right, some will be pointing off to the left. They're all precessing. But if you sum up the direction of all of them, they have no right or left component. They're all going to sum up into a main magnetization vector called capital M that points directly in the direction of Z. So even though the protons individually are lining up at 55 degrees to the main magnetic field, the net sum of all those protons is still going to be in the exact same direction as B naught. So that's the capital M vector. And we're going to hit that main vector, capital M, with the B1 field, a radio frequency pulse. That's going to tilt the M vector away from the z-axis and toward the xy axis. And the duration of time that we need to apply the radio frequency pulse in order to bend at a certain angle is given by a very simple algebraic formula, which comes from integrating all of this. But the basic formula is outlined in red here. The time is equal to the angle alpha in radians divided by the constant gamma times B1. So, for example, if we have a B1 field, which is going to be super small because this is just a brief radio frequency pulse, so it's going to be somewhere on the range of 30 microtesla. And if we want to tilt the M vector 90 degrees, which is pi over 2 radians, then all you have to do is plug in these numbers, plug and chug, just like with most problems here. It's just algebra. So put alpha as pi over 2, use the constant gamma, and make sure your units match up and cancel. So we're going to do megaradians per second per Tesla. And you pump all these numbers through the calculator, and you find that you have to apply your radio frequency pulse for about 0.2 milliseconds in order to turn the angle of the M vector 90 degrees. And so for the purposes of this class, we're always going to change the M angle 90 degrees. Now, as soon as that radio frequency pulse stops, the M vector is going to want to realign with the external magnetic field, B naught. And the time that needed for M to realign with B naught is the T1 signal, sometimes called the longitudinal or the spin lattice relaxation time. We call it a relaxation time because the M vector wants to relax back to its lowest energy state. It wants to be aligned with the external magnetic field. Now, when it does this, the M vector is not simply just standing upright. It spins around in the XY axis and precesses up back towards the Z axis, as shown in the figure. And we're just going to measure the vertical component. We're going to measure the time it takes for the M vector to go back to its original state, which we're just going to call 1. So you can see on the graph, it shows the signal strength as 1. So when the M vector is tilted 90 degrees into the XY plane with no Z component, then the Z value of that vector is going to be 0. And then over time, it's going to realign, and that's eventually going to point straight up. And by the time it points straight up, that's back to its original state of 1. So it just turns out that different tissues will do this at different speeds depending on sort of the proton content of the tissue. And so shorter realignment time, meaning the faster it is to go back to alignment with the external magnetic field, we're going to just arbitrarily call that a brighter signal. So water itself usually takes a long time to realign, about 2 seconds. And we're going to say that's a long time. We're going to classify that as a dark pixel on the image. Other things like fat will realign quite quickly, usually 500 milliseconds, so about half a second. We're going to call that fast, and we're going to label those pixels bright. Also, the contrast agent that we can inject into the bloodstream, gadolinium, it realigns very quickly, and so in about 250 milliseconds. So we're going to call that very bright, a white pixel. So an important concept here is that pixel intensity is determined by the duration of resonance. Okay, and we'll see that with the T2 signal too, although in a different way. So with the T2 signal, so after we apply the radio frequency pulse, the XY components of the M vector are all in phase, meaning they're all aligned, let's say, just all in the X direction. But once the radio frequency signal disappears, they will gradually phase out as some dipoles spin faster than others, depending on the tissue properties again. So the time that it takes for the magnetization vectors to lose coherence is called the T2 signal, sometimes called the transverse or spin-spin relaxation time, because you can see this this magnetization vector is perpendicular to the main external field. So that's why it's called transverse. It's also spin-spin because it's spinning in the XY plane. So we're concerned here with the XY component rather than the Z component. And as this dephases, a longer transverse relaxation time, we're going to call a brighter T2 signal. So water resonates for quite a while, about 4 seconds. So we're going to call that a bright pixel. Other things like cartilage resonate for only about 50 to 100 milliseconds. We're going to call those dark pixels. Brain tissue is kind of in between. It resonates for about 1 second, so that's sort of an intermediate gray pixel. And you can see here that the signal starts as 1. This is immediately after the radio frequency pulse ends, and then it will gradually, the magnetization vector, as it realigns with the external magnetic field, and as it dephases out of the XY plane, it will gradually drop to 0. Now you can see here that these look like exponential curves, and that's because these, again, are exactly the solutions to the Bloch equation that I showed earlier. So the physics and the mathematics and the reality all happen to match up here, fortunately. When Bloch originally conceived of these ideas, he really didn't know that it was going to lead to the ability to image human bodies. He was much more interested in the atomic, quantum sort of behaviors and the mathematics. So sometimes you just don't know how your theoretical work is going to lead to revolutions in other fields. MRI, more than anything, has really revolutionized medicine. I'm taking a little side point here, but it used to be that to be a good neurosurgeon, you had to be first a good neurologist and a good surgeon, and you had to do a full neurological exam. It took a long time. Typically, you tried to pin down where you thought the tumor was based on your neurological exam, for example. But now we just have MRI machines that can scan someone and show you exactly where something is and where to operate. And so the whole neurological aspect, unfortunately, has been lost for a lot of neurosurgeons. But anyway, back to the topic. So this next image is just showing how we get a T1 signal measurement. You can take the slope and project it to get a specific T1 time. And same thing for the T2 measurement. We can get a specific T2 time for each location based on the slope of the exponential curve. So the next question, obviously, is how do you spatially locate each proton or a group of protons so that all these independent relaxation times can be used to recreate some sort of spatial representation of the tissue? Obviously, NMR doesn't do this. When you put a chemical substance on the in your NMR machine, it just tells you what is there. It doesn't tell you where it is. So how could you possibly do this? This is sort of a Socratic question. How would you do it? If you could come up with this, obviously you would also be a brilliant inventor of the MRI machine. And there was a lot of people that worked on this and made this happen, but the basic concept is simply to make a gradient of strength in the external magnetic field. So, for example, if we're doing some sort of whole body MRI, let's just make the field weak at your feet and make it much stronger towards your head. Well, you remember the precession frequency of the protons is going to be directly related to the magnetic field strength, which means protons are going to be precessing slower towards your feet and faster towards your head. And so what we can do is use that precession frequency from toe to head and do a reverse Fourier transform. And that Fourier transform will essentially show us the spatial location of each proton based on how fast it's precessing. So this is a brilliant idea. You remember when we talked about EEG, we talked about taking a time signal and doing a Fourier transform to convert it into its frequency domain and see all the frequency peaks. Well, here we're kind of doing the inverse. We're taking all the frequency peaks and we're doing a Fourier transform, but not back to a time domain. We're doing it to we're just going to change the name of the variable. We're going to do it to a spatial domain. So the equation for the Fourier transform is shown here at the top. It shows the signal through time, how it equals this double integral, double because we're doing it both in an x and a y direction, of the spatial function times the exponent e to the power of something. Here we have again e to the power of j is the square root of -1. So this is going to be some sort of oscillating function. E to the power of the negative square root of -1 times 2 pi times the Larmor precession constant times these phase functions times time, integrated all with respect to x and y space. Now, you don't need to know the Fourier transform equation, obviously, but it is cool to see how the previous equation that we talked about, omega equals gamma times b, that wasn't just to be tedious, that actually was the key to all of MRI. That's how we get our spatial information. The pixel location is determined by its frequency. The pixel intensity is determined by the duration of resonance. If you want, you can think of an analogy here, an analogy of choir singers. The T2 signal is kind of like me being the choir director and hitting the choir with a radio frequency pulse that tells them to sing a note for as long as they can. The strength of the T2 signal is represented by how long each person holds the note. Now, what note they're singing would show their position in the choir. If they're singing a high note, they might be towards one end of the choir. If they're singing a low note, they would be towards the other end of the choir. So again, the frequency shows the position. Now, the resonance strength of the T2 signal, the duration that they sing after I pulse them, that is the strength of the signal, or in other words, the pixel intensity, whether it's white or whether it's darker. Now, the T1 signal is kind of like I punch the singers in the gut with a radio frequency pulse, and it knocks the breath out of them. The time that it takes for them to recover their breath is sort of like the T1 signal, the time to realignment with the main magnetic field. So, and again, the frequency, the note that they're singing would represent their position. Now, if that seemed confusing, that's okay. It's confusing the first time you hear any of this. It might help in this next part to actually see the mechanics of the MRI machine and what the parts are doing. So let's go through that, and then if it still doesn't make sense, you can go back and listen to the first part again. Now, the MRI machine is made up of some simple parts, actually. It turns out you could probably build one of these in your garage if you wanted to. The complexity is not in the parts. The complexity is in the software and the mathematics. So that's the difficulty. So an MRI machine is composed of some simple parts. The main magnet, which is what generates the main magnetic field, the B0 field. So the most efficient way of making this is to supercool it with liquid helium and make a superconductor out of the coil, so you can just turn on the electricity, pump it through this electromagnetic coil, generate a large magnetic field, and then basically shut off the electricity and let the superconductance just maintain that current flowing around, and it maintains a magnetic field. So you don't need to put much energy into the system at all to maintain that magnetic field. Secondly, you're going to have gradient coils. These are what make it possible to image spatial information. So you have to make a gradient of the magnetic field. For example, make it weak on the left side and strong on the right side. Or you make it weak at the bottom of the tube but strong at the top of the tube. So you make these different gradients in the X, Y, then Z planes. And that's how you get your spatial information, is from the gradient coils. And the last important part is the radio frequency coil. This is both what generates the radio frequency pulse that tilts the magnetization vector, and it's also the coil that receives the radio frequency signal and then sends that to the computer to decode it and interpret it for both pixel intensity and spatial information. Now that would just come through as a voltage change. It's this big oscillating wave of voltage, but that's what we're going to do the Fourier transform on, to extract both spatial information and pixel intensity information. Now, the radio frequency coil, I should say, it can be built into the MRI machine itself, but typically it's much more, it gets a much better signal when it's closer to the body part that you're imaging. So typically we build radio frequency coils that fit over specific body parts, like a radio frequency coil for the head or for the knee or for the shoulder or things like that. Now, remember with CT scanning, we talked about how the only sort of contrast modality that you have is how dense is the tissue to X-rays. Well, here in MRI, there's a lot of ways to adjust and play with the different types of signals that you can get. So one of those is we can adjust the tilt angle of the magnetization vector via the length or duration of the radio frequency pulse. We can also adjust what's called the time to echo, meaning the time interval between the radio frequency pulse and the measurement of the signal. And we can also adjust the repetition time, meaning that we can give multiple radio frequency pulses and see how it affects the tilting of this magnetization vector M. So all these different pulse sequences enable different ways of getting contrast. And we talked about these different modalities already. The T1 signal where water is dark. We have a T2 signal where water is white. And then we have a flare, which is probably one of the most useful imaging modalities for neurological applications because it's basically a T2 image, which then subtracts the exact signal of water. And that makes the CSF dark. So anything that is inflamed or swollen or edematous will show up, the fluid will show up in the tissues. So, for example, an area of edema around a tumor or around an infection, those kind of things will show up really obviously with a flare signal. So it's almost like you don't even need to be a neuroradiologist. You can just look at it and on a flare, look for where the white spots are and say, whoa, that's probably abnormal there. And then the last that we talked about was diffusion-weighted imaging, which is based on the random motion of water molecules, and it estimates this apparent diffusion coefficient. And remember, historically, interestingly, Einstein, the way he estimated the size of an atom was by estimating the diffusion coefficient of water. But here we're using that signal, the motion of water between measurements, to essentially show us how fast it's diffusing, and that can give us an idea of basically whether the tissue is infarcted or not. So a DWI is much better than T1 or T2 images for detecting ischemic brain tissue. The problem with CT scan is that the most common CT scan you see with an acute stroke is a normal CT scan. A stroke isn't going to show up early on in a CT scan. So a stroke is a clinical diagnosis. It's not a radiologic diagnosis. But DWI really narrows down what we can do. We can get a better sense of whether the brain is ischemic early on, hopefully within that 3 to 6 hour window where you can actually do something like fibrinolytic therapy or anticoagulation therapy. Now, the DWI and ADC signals, I mentioned earlier that they're generally the inverse of each other, but because DWI contains a little bit of T2 weighting, the crossover of the signal intensities occurs at a slightly different time in the intermediate phase of a stroke, around 1 to 3 weeks. So you can really differentiate how long ago a stroke occurred with these imaging modalities as well. Now, there are also a lot of cool research projects going on in MRI. They're always trying to find new imaging modalities, like how do you image Alzheimer's? How do you look at like time of flight or proton density or all these cool things. They can even use really strong magnets, like up to 18 Tesla, to look at protein structures. Remember, the strength of the magnetic field B0, that is directly proportional to not only the signal strength, but also the slice thinness that lets you really get high resolution. So all sorts of cool things. One of these imaging modalities is called diffusion tensor imaging. It's a type of diffusion-weighted imaging where it uses the motion of water molecules to estimate the overall direction of water diffusion in 3D. So in the same way that you look at the motion of water in a pixel, for example, they're doing it in a voxel. A voxel is like a 3D pixel. So they can average the diffusivity of these water molecules, both their magnitude and direction, and then assemble these little vectors of motion to make these tracks. So it's really cool. It's called tractography. You assemble these vectors into single tracks. It's limited a lot by resolution, unfortunately. So, a little over a millimeter is the best they can do right now. And you can imagine there's a ton of axons that can fit in a millimeter by millimeter space. So not super high resolution yet, but at least it gives some idea of the connectivity of the brain. Another cool research tool is functional MRI. This is a way of trying to gauge activity in the brain. It measures the ratio of blood oxyhemoglobin to deoxyhemoglobin. It's the BOLD response, the blood oxygen level dependent response. Now, there's a lot of assumptions that go into this. We're assuming that more neural activity in a localized area will cause more blood flow, which causes an increased amount of oxygenated hemoglobin to come in, and that increase in signal arises from that oxyhemoglobin. But you have to consider some caveats. If neurons need more oxygen and create a more acidic local environment with higher oxygen tension, presumably the hemoglobin should release more of its bound oxygen, which could also create more deoxyhemoglobin. And some areas may not actually have this tightly coordinated vascular response to neural activity. And there may be some lack of validation of fMRI with reality. All of this can be reviewed in several research articles, one of which actually shows that the statistical techniques that were used for many years to evaluate whether an activity in a certain area was significant compared to control, that those statistical methods were flawed, and it invalidated a lot of research that had been done in this. It also has poor spatial and temporal resolution, the spatial resolution being several millimeters. And it also doesn't really tell us anything interesting about the circuitry that's going on. For example, I don't really care where something in the brain occurs. I'd rather know what's the circuitry that makes it happen the way that it does, what's the underlying mechanism. So just some things to think about there. Another point that's important to cover is MRI safety. So obviously, whenever you go into an MRI room, you have to be super safe about what you have on you. You don't want anything magnetic at all, belt buckles, pens, other things. And with patients, this is especially important. This picture shows someone who wheeled a bed into the MRI room, and of course the bed got sucked into the MRI machine. Same thing with anesthesia equipment. It's critical. There have been recent cases even where people have died because someone brought in an oxygen tank for the anesthesia machine, and the oxygen tank flew into the MRI machine and smashed a kid's head. And so these things are really obvious, you would think, but there's safety measures in place for a reason, and you really need to follow the protocols and be aware of what you're doing. So also, MRI safety comes into play with implants inside patients. So we try to classify these. You can not only can you get magnetic parts like metals and things moving around in the body, but they can also heat up. Whenever you have a magnetic field, you push electrons, you push electricity through that metal, which can heat it up. And so you have to worry about internal burns as well. It turns out if you just loop the wire around so that it makes a 360-degree curve, it will typically cancel out any current flow in one direction or the other. So that's a pretty simple solution. But devices have to be carefully recorded and documented, and FDA classifies them with all sorts of specific classifications. So it's good to be aware of those. And you can actually use specific MRI protocols to minimize the risk for people that have certain types of implants in their body. Okay, so in summary, MRI has the advantages of extremely good tissue contrast and extremely good resolution, even without contrast agents. So it's the best choice for trying to get detail, especially around bony structures that would be obstructed by CT scan X-rays. So especially the spinal cord, the brain, things like that. We can also get many different types of tissue imaging contrasts with different sequences, different modalities. that really help us pinpoint the diagnosis. And it's no ionizing radiation. It's non-invasive. It's incredible. The disadvantages are that it's very slow, it's expensive, and it's a quite uncomfortable environment. If you've ever been in one, they're a very small hole. It's not like the hole on a CT scanner, which is large. MRI needs to have a very homogeneous external magnetic field through the body, and so in order to do that, it has a very small hole that's elongated, and this can be very claustrophobic inducing to patients. So it requires cooperation. Patients have to hold still for a long time, and this can cause problems, especially with kids. So usually kids need to be sedated, and then that brings the problem of having to bring in anesthesia equipment into the MRI room. So there's all sorts of problems just logistically. And of course, there's also danger with magnetic or conductive materials in the body as well. The next type of imaging I want to talk briefly about is angiography, just in order to be complete. So classically, an angiogram is just taking an X-ray while injecting some sort of radio-opaque dye through the vessels. And so you can get an X-ray with the vessels lit up on the X-ray. Or if you record a video of this, it's called fluoroscopy. Now, the dye is typically a radio-opaque dye, so something that's opaque to the X-rays, like an iodinated agent, something with iodine attached to it. And you can also use other types of dyes for MRI. So if it's paramagnetic, you can use something like gadolinium to make a contrast agent for MR images. And then with those, we can actually extract angiograms. So these are like the modern day angiograms, a CT angiogram or an MR angiogram, which subtract out all the other tissues to give this detailed view of the vasculature itself. If some sort of pathology or lesion in the tissue lights up with the contrast agent, we say it's contrast enhancing, or more commonly, you'll just hear the term enhancing. It's an enhancing lesion. So many types of lesions in the brain, like tumors, infections, and other things, show up as enhancing lesions. So typically, you would say the contrast in the blood should not cross the blood-brain barrier. But when it makes these sort of enhancing lesions that shouldn't be there in the brain, we know something is wrong. Now, with MRI, you can imagine that since T2 signals already show water and blood as bright, there's no point in putting in a contrast agent into a T2 image. So almost always we use a T1 image with contrast. And that gadolinium with a T1 will show it'll show the vessels and any other enhancing lesions along with the normal T1 image tissue. So we're actually just going to go through a bunch of different images together, kind of like how you teach an artificial intelligence system, a neural network, a neural node system, how to learn things with examples, or you teach a child with examples. I think that's actually, in this case, much more efficient than trying to teach all the rules and all this mumbo-jumbo without actually looking at examples. So let's start off by looking at the fundamental types of cerebral hemorrhage on CT scan. First, we have epidural hemorrhage. This is bleeding between the dura and the skull. It bulges and makes this sort of lenticular shape, often with a skull fracture that you can see in the bone window. There's a subdural hemorrhage, which is between the dura and the brain. It shows up as a crescent shape, typically from the tearing of the bridging veins at the surface of the cortex. And this often occurs either in really young age, like with child abuse, or in old age, such as when an elderly person falls down and the brain is atrophied, and so it can slosh around and it tears all those bridging veins and makes a slow bleed. The next type is subarachnoid hemorrhage. Remember, the arachnoid matter can follow vessels through brain tissue, so if there's some sort of aneurysm in the artery and it ruptures, that blood will track in the subarachnoid space. And so these ruptured aneurysms have a very characteristic subarachnoid hemorrhage, and this is one type of hemorrhagic stroke. Now we have intraaxial bleeding. So extraaxial is referring to the fact that the blood is coming from outside the central nervous system. Intraaxial, it's actually coming from inside the central nervous system. So intraparenchymal hemorrhage, sometimes called intracerebral hemorrhage generically. This is just a rupture directly into the parenchyma of the tissue, the parenchyma being the brain tissue itself, the functional tissue. This is also a type of hemorrhagic stroke. And then we have intraventricular hemorrhage, which is just bleeding into the ventricles. This often occurs, for example, in neonates that are premature and have oxidative damage to the choroid plexus. We looked at some histopathology of this in the first half of the semester. So you can see on all of these CT scans, when we make the brain tissue bright enough to look at, it makes the bone really, really bright, overly bright. And so in order to look at the bone windows, you have to really bring down that brightness. And that's called a bone window. When you really enhance the brightness to look at the brain tissue itself, it's called a brain window. And now to jump to MRI, I'm actually going to go to a pretty confusing image, because this is actually an old image taken from one of my old textbooks. This is when MRI was just being introduced clinically in the 1980s. And you can see here the skull actually looks quite white, which is unusual for MRI. Normally the skull is going to not show up much at all. It'll be very dark. And so here it's actually showing up white. So this is confusing because it almost looks like a CT scan. But the clues that indicate this is in fact an MRI are, one, even the skull itself shows a lot of detail. You can see this sort of intralaminar membranous formation within the skull itself. And then also the brain tissue is highly detailed, much more so than a CT scan. So those things will give it away. Now on the left, we just have a normal T1 image. In the middle, we have a flare, which again will cancel out any sort of water signal like the cerebral spinal fluid, but anything that's edematous or inflamed should show up as white. And we see this large sort of portion of edema in the left hemisphere. And then when we inject contrast, you can see all the little vessels that light up on the T1 image. This is on the right side of your screen. You can see all the little blood vessels lighting up with contrast, and then smack dab in the middle of the white matter in the left hemisphere, you see this enhancing lesion, some sort of tumor that shouldn't be there, and that's what's causing all the edema that you see on the flare image. Now again, as I mentioned before, with an enhancing lesion, the differential diagnosis on this is extensive. It could be many, many different things, anything from tumor or metastatic tumor to an infectious process, an abscess, to an infarct or some lymphoproliferative disorder, some demyelinating disease. It could be a lot of things, but typically there are various clues that'll help you pinpoint what it is just from the imaging alone. Now, from here on out, all the images that I'm going to show are from my own clinical experiences, and all I want you guys to do, you don't have to identify the pathologies for the exam. All you have to do is be able to recognize the type of imaging that it is. Also, any images that I show you are exactly what would appear on the exam. I'm not going to give you images that you haven't seen before. Now, all these images I've de-identified, and so there should be no patient information shown here. So the first image that I'm going to show you is an angiogram. Here we have an injection of contrast agent injected directly into an artery, and if you look really closely, you can see that the skull has been digitally subtracted out here to make the angiogram. So the back of the head, the base of the skull is on the left side of the screen, and then the face would be towards the right side of the screen, although you can't really see the face here. But the big, thick artery that you see going up at the top there is the basilar artery, and right at the top of it, you see a little outpouching. This is a top of the basilar aneurysm. But again, all you have to do is recognize the type of image that this is, an angiogram. The next set of images is an MRI. Now, when you see an MRI image, you need to identify what type of imaging modality it is, whether it's T1, T2, or flare. And if it's T1, you need to identify whether it has contrast or not. So on the left is a classic T2 image. The cerebral spinal fluid appears white, the cortex appears light colored, and the white matter appears a little darker colored. In the middle, we have a flare image, and you can tell this because there's some edema showing up as white, but the CSF itself is black. And then on the right, we have a T1 image with contrast. You can tell this because the vessels are clearly lighting up with a little bit of contrast agent, and the central cerebral spinal fluid is dark. This one is actually a little tricky because this is actually a cavernous malformation. I remember on residency interviews being quizzed on stuff like this and miraculously getting it right. But this is all the same patient. You can see there's a small little cavernous malformation down at the bottom left at the back of the lateral ventricle, and it's causing a little bit of edema around the ventricles as well. And that's why the flare is showing up with white. You might think that's a little confusing. How do you know for sure it's flare and not a T1 with some white swelling? But you can look and see, because the water signal has been subtracted out, the ventricles are completely black, whereas on T1 the ventricles are a little bit slightly grayish, if you will, even though the cerebral spinal fluid is still black. Next is a T1 image, MRI, T1 with contrast. So again, you can see here some enhancing lesions. That gives it away that you've injected contrast. So these are from a lymphoproliferative disorder, in this case a classic B-cell lymphoma after organ transplant, but they could have also been other things like tumors and abscesses. Next we have the classic CT scan. Again, this is all the same patient, and the S with a line over it is like sine Latin without, kind of like Spanish sine, and C is con or with. So this is a CT on the left without contrast, and then in the middle with contrast, and then when you subtract out the other tissues, you have a CT angiogram on the right. This shows a giant ruptured aneurysm. On the left is how the patient came in. In the center is post-op, so you can see a bone flap has been removed. The next image shows the same giant aneurysm, but this is under a fluoroscope, so this is an angiogram. A dye has been injected, and it shows the filling up of this aneurysm. This shows the progression filling up from the arterial to the venous phases, and if the images had gone on a little longer, you would also see it start filling up the major sinuses like the sagittal and sigmoid and transverse sinuses. The next image shows two CT scans. On the left is a normal CT scan. The bright densities that you see in the ventricles there, that's normal. Those are calcifications in the choroid plexus that occur with age. On the right, however, is obviously not normal. This CT scan shows some sort of massive amount of blood in the cisterns, probably some sort of subarachnoid hemorrhage and ruptured aneurysm that's been operated on. You can see a bone flap missing on the patient's right side. And I put this up simply to remind you not to be confused that just because there's blood there filling these cisternal spaces, don't confuse that with contrast in the vessel. This is not contrast in vessels here. Both of these are CTs without contrast. The next image shows a nice comparison between a CT scan and an MRI on the same patient. So this is a patient who had a cardioembolic stroke. It showed up as a small stroke on CT scan. You can hardly even tell that anything is wrong there, but if you look, there is some amount of small hypodensity near the lateral ventricles that has a little punctate point of probably hemorrhage in the center. So you can barely tell on this CT scan that it's there, only if you're really looking for it. But on the right, on the MRI with a flare, you can see that it's just blaring, it's glowing out at you, that there's something edematous, and this is showing little spots of infarcted tissue. And on this same patient, if you do an MR of the vessels, you can get an MR angiogram, an MRA, and this is what it looks like. You can see here that this is very fine resolution. This can actually be rotated in three-dimensional space, and it will show up as a very high-resolution image of the vessels with a nice subtraction of all the other tissues. So much better image than a CT angiogram. Next, we have a patient with an atherosclerotic disease. This is carotid stenosis. You can see here that there's actually an X over the pathology on the image on the right that is facing towards us. So you can see that the right internal carotid artery has essentially disappeared. Compare that with the left side where you have a large, thick carotid artery there. So where the little X is marking it shows that it's highly stenosed. It's almost totally occluded. There's a thin little amount of blood that's making it through there. But surprisingly, the vessels in the brain are lighting up. So this is obviously with contrast, and this is a CT scan. You can tell by the bright bones. So a CT with contrast. Now the vessels in the brain are lighting up because we have this awesome thing called the Circle of Willis. Thomas Willis was the anatomist at Oxford and discovered this sort of vascular flow pattern that enabled the brain to survive even when we have a internal carotid stenosis like this. You can also see it in the image on the left. You can see the thin, almost like a tree branch that's thinning out as it goes up. Now, if we take that same patient, a little while later, we find out that unfortunately something has gone very wrong. So here we can see what looks like a very low resolution image. There's no bone around it though, it's only the brain, and it's showing us this bright intensity. This is a classic diffusion weighted image. So this is MRI, but the diffusion weighted image is averaged over time, and so it looks lower resolution. But this is showing us that nearly the entire right hemisphere has been infarcted. And now when we look at the CT with contrast on the far right, we can see that the vasculature is no longer perfused. The blood is not getting to the brain any longer. So unfortunately, this is a massive hemispheric stroke. The next patient that we have is actually a very interesting and sad case. So this was a lady who was on a long flight, and you remember on flights they always tell you, well, get up and move around, stretch your legs, flex, so that you don't get deep vein thromboses. Well, unfortunately, this lady got a deep vein thrombosis, but it wasn't in her legs, it was in her brain. You can see the straight sinus is filled with hyperintensity. This is on a CT scan. The bone is bright, and in the acute phase, blood clots will also show up bright. So you can see that the straight sinus not only is showing up bright at the top left, but also at the bottom left. You can see that it looks like there's a clot directly in the straight sinus that's blocking it and filling it, engorging it with blood. Now you might think, oh, well, maybe we could put a catheter up in the vessel and use some fibrinolytic therapy, bust the clot. But you can already see that there may be a little bit of subdural hemorrhage there forming as well, at the top left especially. So unfortunately, in these sorts of cases, what often occurs is after the blood is clotted, pressure can build up, and you can convert from being overcoagulated to hemorrhaging, and that's what happened in this lady. So you can see on the right images, the straight sinus is still clotted with blood, and there's been a massive intraparenchymal hemorrhage. And in the bottom right is post-op after sucking away a lot of the blood to remove pressure. You can also see in the image at the bottom right, you can see that on the left side there's a bright little spot going into the patient's right lateral ventricle, which that's an external ventricular drain, so that also is helping relieve pressure. The next image shows what are obviously MRI scans. So these MRI images are of the spine. Typically with the spine, we like to do T2 images because it shows us the cerebral spinal fluid as bright white, and it shows a nice image of the spinal cord that looks like the natural tissue. Unfortunately, in the patient on the left, this is a case of von Hippel-Lindau disease. So these are hemangioblastoma tumors. Sometimes these can be resected surgically. Sometimes you need to use stereotactic radiosurgery, and there can be other associated tumors with this. But unfortunately, there's not a whole lot you can do to restore function. So with the image on the right, this also is a very sad case. This was a motor vehicle accident, and this man was he had a spinal cord injury. You can see an anterolisthesis, meaning the cervical vertebrae have slid forward off of the spine here, and there's impingement on the spinal cord. The disc is pushing and causing it's a crush injury, basically, of the spinal cord. So this man was quadriplegic. This next image shows some CT scans on the left, so you can see on the leftmost image what looks like a relatively normal CT scan, but there's something, once you look closer, you can see something's not quite right. Now, if we use contrast, as we did in the middle image, you can see something is definitely not right. This was a 55-year-old guy who had his first seizure and unfortunately ended up having a glioblastoma. If you remember back to when we talked about histopathology of glioblastoma, that's what this man had. So you can see at the right frontal lobe some sort of mass that is enhancing with the contrast. And then we can also see on the MRI image on the right, the flare. You can tell this is MRI again because it's high resolution, the bone is dark, and you can see that the cortex is light while the white matter is a little darker. So this clues you into this is not a normal T1. This is a flare image where the water has been subtracted out, and so it leaves just the edematous portions around the tumor showing as white. You can't see the ventricles themselves because they're essentially the edema from the brain has probably closed them off. Plus, we're kind of high in the brain, so maybe the ventricles are a little lower too, but that's what's going on there. Next, we can see here 2 CT scans where this patient was in a motor vehicle accident and was impacted on the right side of the head, which left this large intraparenchymal hemorrhage in the right hemisphere. You can see that on the left image. Now, on the right image was this other thing that I put up simply because it's pretty amazing how often this gets missed, and it was missed early on. It wasn't until the ICU that we looked back at the imaging and saw this, and you can see here you have your foramen magnum, and those things going through it, that's your spinal cord and your vertebral arteries. And in the vertebral artery on the right, you can see a large white dot in the wall of the vessel. That is a vertebral dissection. And these frequently happen anytime the head gets impacted or twisted. They can cause strokes and things in the brainstem. So these are important to look for as well. Lastly is one of the most interesting cases that I've seen. So this was a girl, 16-year-old girl, who was surprisingly normal, only slightly delayed in school, and had started having her first seizures. And once we did imaging in the brain, quickly realized things were not even remotely close to normal. This is a giant arterial venous malformation. And amazingly, the neural tissue was intact enough that she functioned fairly normally despite this massive malformation of the vasculature. So I was lucky enough to be able to see one of the most talented surgeons I've worked with try to repair this lesion, and did an incredible job. So anyway, I hope that's all been interesting to you. Hopefully some interesting cases and some interesting applications, and maybe that gives you a better sense of how to look at a scan and know what you're actually looking at. So like I said, you don't have to know the pathologies. I just want you to be able to identify the type of scan that you're looking at. All right, guys. Well, thanks for a wonderful semester. Sorry we couldn't be together for a lot of it, but I have missed your questions and interactions with you guys, and hopefully this hasn't compromised your education too much. I try to make these videos informative and useful and efficient. I will try to put up some of the other online lecture stuff that we did from previous, like the autonomics if I can, so that you can go back and review that information. If you have any questions, again, please feel free to email me, and I wish you all the best. Thanks, everyone.